1, 2.
Good afternoon and welcome to this afternoon's information session at the COVID Communication Center. Today's topic is on transmission and the testing and response strategies. The speakers today will be Dr. Petrus Marta, a World Health Organization expert, Bonnie Nakumbi, the acting COO from NIP, and then Dr. Bernard Hafuku, Namibia's National Coordinator of the COVID-19 Task Force.
As I made in my statement that COVID is a new disease, we did not have the capacity to do tests on COVID. It never existed. But when the world started experiencing COVID, we then built up local capacity. Initially, we could not test locally, but then we built up local capacity with NIP gradually. And we then put up criteria who can be tested. And mostly the initial criteria was focused on those who are suspected of having COVID-19. This was because by then the NIP did not have much capacity to do almost everybody who need to be tested. But gradually we build up that capacity. Now currently we are in a position to do 96 per run. We can have 1 run or 2 runs as long as there are specimens to be tested. The reason why we are not doing much currently is because of 2 things. Number one, the criteria we have put up. That's number one. And then number 2, we have to preserve the little reagents we have. Because as you know now, the whole world is looking for this reagent to test their citizens. There is a scarcity of these reagents. That's number one. And also, as you know, that transport has been stopped. It's no longer easy to get things from outside to bring into Namibia. Either you have to charter a plane to go and collect where the commodities are to be found. So, but I must say that we have now revised our criteria. We are going to do as many tests as possible, but as I said, we will focus on the hotspots when we know that here we are likely to have transmission going on, because again the reagents which we have is not enough to apply to everybody. Yes, we had some reagents, test kit from Jack Ma. We have received that, and I believe you were also at the ceremony where it was received at the Ministry of Health and Social Services. Many of the journalists were there. They have witnessed the donation. But when it was looked further, there were some small components which were not together with the donation, and these ones were being sourced.
This morning, obviously there are issues around the COVID-19 virus that the people are asking themselves. And there are obviously several parameters that come into play, especially issues that are of concern to our citizens. So this afternoon, we will be looking at the issues of community and local transmission. We'll also be looking at the issue of update on testing in relation to our response, our strategic, our response strategy in regards to the virus. And joining us on the set, we have Dr. Bernard Ausiku, who is the National Coordinator of the COVID-19 Task Force. And then we have Mr. Bonnie Makumbi, who is the Acting Chief Operations Officer of the National Institute of Pathology. And then over here we have Dr. Petrus Mhata, who is the WHO, the World Health Organization, Emergency Preparedness and Response Officer. So, good afternoon, gentlemen, and welcome.
Good afternoon.
And of course, a warm welcome to all our viewers and our listeners on all NBC's platforms. Can we begin with you, or perhaps you, Dr. Mhata? What exactly is community and local transmission? I'm sure we all would want to know what exactly it is and how this can affect our communities.
Thank you very much. Maybe let me take the audience and the listeners through the 4 scenarios, the 4 stages of COVID transmission. The first one is where the country doesn't have cases. It is called no cases. It's the first scenario where we don't have cases reported in the country at all. The second phase or stage or scenario is where you have sporadic cases. This is where you have one or a few number of cases, and these cases have basically been imported or locally acquired around the imported cases. Then the third stage is where you have cluster of cases. This is now where most of the cases are from the local transmission, and these are also linked to the chains of transmission that are already known. Now, the fourth stage, fourth scenario, is what is called community transmission. Here, there is an outbreak which really, and you cannot attribute it to the already local clusters or imported cases. You have an outbreak and you cannot link it to any of the known cases that have been reported already. So, and even if there are sentinel surveillance laboratories going on in that country, so most of the cases will become positive for COVID. So this is now where you don't really know where cases are. Maybe that every few number of people in the community are infected. So I think that is more of what community transmission is, and we should, if we don't have it, we should by all means try to prevent us to reach that stage by really improving and strengthening our prevention strategies.
Thank you. Dr. Ausiku, do we have, at this point in time, do we have any infected people with the virus in the community, local transmissions? Where do we stand now?
Well, thank you very much for the question. I appreciate it. It's very difficult at this stage to say that we have community transmission. We can only suspect, and we have very good reasons to suspect. Why I'm saying that is that so far we had imported cases. We tried to capture them. We tried to trace those people who were in contact with these imported cases. We captured as many of them and put them in isolation, and those we tested to be positive, we treat them accordingly. That is what we call passive surveillance strategy, and that is what really we have been following. More targeted, more focused strategy, but not what we call active surveillance. Now, active surveillance, we have an epidemiologist here, I will tell you more in detail, but basically what it means that we go out, even in this room, and we take out 3 or 4 people, even if they're not coughing, and then we test them. We go to the hospital outpatient department, we test them, or we go to a shop and get about 3 or 5 people and test them. We go to the lab or so. And then we get a sample that is enough, what we call enough powered, meaning a good number of people that we test, and we see how many of these people we tested will come out positive. And these people should not have a traveling history, because otherwise it's not community transmission. They must be just people who live here in their normal life. Some of them may be having flu symptoms, not meeting all the testing criteria. Then we can make a determination, yes, we have community transmission. At the moment, we can only suspect, and I have a strong suspicion that we have community transmission. It's a matter of finding it. Why I'm saying that is because we are almost 2 months plus into the pandemic. Hardly happened that community transmission doesn't take place. Maybe not symptomatic, but there must be some activity brewing underneath there already. Yeah.
Saying that we can only suspect, yes, that we, who would these suspects be? Who would we suspect?
There are 2 points on the suspect. One is that it's possible that the virus is multiplying in the community with a lot of people being asymptomatic. That's a possibility. Another one is to have so many what we call passive carriers who don't fall sick, especially young people. And by some sort of luck or some environmental factor or some other factor we may not have identified, it doesn't flare out. But we also have to say thanks. Our interventions also hammer in a way, because we locked the borders, we locked regions, let's say a lockdown we are talking about, and perhaps by then not so many people have been exposed to the virus. There's that possibility. But it's something I would be surprised by, and very, very pleasantly surprised, that we only have these 16 cases linked to the imported cases. And then we go down to June, July, not picking up others. That will be a very, very pleasant and unusual surprise. Something that's worth more investigation to find out exactly what are other determinant factors that made Namibia so unique, because we are basically on top of the world. If you look at the graphs, we are one of the best doing country, as much as we haven't tested enough. But if you look at the 16 cases, and you go back in time, for the last 10 days, no case was picked up. But we've been testing every day. No case picked up. The drawback is the fact that we tested far, far fewer people than we should. But we also tested them according to defined criteria at the stage where we were. So it's not a bad or entirely bad thing. All we need to do is perhaps to test more, to also build up database, because these are the issues that are guiding our strategy. If we go to May 4th and we still have 16 cases, what's the point of lockdown anymore? So we need to be guided by the data, and we get the data by going in the field and do more testing.
So what you're saying, in essence, is that, well, I don't want to be pessimistic, but what you're saying is that the figure of 16 is just a little bit too good to be true.
Yeah, I'm not really a pessimist, and I wouldn't want anyone. In this difficult time, nobody should be pessimistic. We must be perhaps cautious optimistic. That's the term. And it's a very delicate balance, by the way. We're talking about the lives of people, which we need to protect, but we also have an economy at stake, so all of these things must come into play, and then we must balance very, very delicately. So it would be dangerous for us to assume that
yes,
the 400 cases we tested are the only one. Scientifically, it doesn't even make sense. But it would be a very good thing to assume there are some more there, and we try to test. Even if we don't pick up anything, then we will be relaxed and say, look, we have done our work, rather than assuming based on the number of the cases that we have tested.
We also had the issue of the 85 returning Namibians who were let out, who were allowed to go home without being quarantined. So there is a possibility that they could also be carriers, and they could also have infected.
Absolutely. remember, I don't want to create a one-on-one conversation, but remember that the vast majority of people who get infected actually don't get serious symptoms. Some of them are asymptomatic up to the end of the neutralization of the virus in their body. As far as 80%.
But they're still infectious.
But then they pass it on to somebody. And these are the people we call super spreaders. Children who are attending school, like primary school, are among the super spreaders. And that is actually part of the reason why school needed to be closed, to avoid these super spreaders picking up the virus at school, taking it to their parents and grandparents, and making their grandparents sick, and they themselves not actually falling sick.
Well, we've heard and we've seen actually with the virus throughout the world that testing is of the utmost importance. So let me turn to Mr. Bonnie Makumbi, who is the Acting Chief Operations Officer of the National Institute of Pathology. And your institute is the one that has been doing the testing in Namibia. So how is that going? Are you able to test? You've only tested 400 so far? Is that right?
Yeah, so far we have tested about 338, but this includes retesting for those positive ones. The rest of the figures is tested by NICD through our complementing lab, PathCare, and we are doing well. We are ready. As of today, we have a capacity of being able to test about 2,000 tests as we speak. But as we move on, if our suppliers delivers according to schedule, as of this week, end of this week, we're able to have stock to be able to test between 20 and 30,000.
Where is the stock coming from? You're saying if? So it's dependent on if you get supplies?
Yes, we have suppliers all over the world. We procure on emergency basis from identified suppliers in South Africa, in Europe. So we have orders placed as we speak, and we have expected delivery dates, and they spread from this week up to end of the month. We are building capacity in terms of, we are using currently auto or semi-automated methods as we speak. And this makes us have a turnaround time of results about 24 to 48 hours from the time of collections. Some specimens, of course, are coming from outside Windhoek, but it's still within the same turnaround time. Towards the end of this month, we are expected to move into a more automated testing methods because we are ready. There are equipments already in our laboratories which are automated, but we are still waiting for the delivery of the reagents so that we move over to these testing methods. Some of these testing, one instrument can run 470 tests and in 24 hours. So if we have 3 of these, which we shall have, we should be able to run 1,410 tests in 24 hours. And some of these test instruments are also already, we are using them, for example, for TB testing. These are the gene experts. We have a gene expert in every lab. But our rollout plan, of course, will be determined by the number of cases, either suspected cases or, as the Ministry of Health decides, whom to test. So we are moving towards meeting the demands as events unfold. So in terms of personnel, at the moment within Windhoek Central Lab, we have about 10 medical scientists who are trained to be able to do these tests. In other words, should testing suddenly increase, we have the capacity in terms of personnel as well to break our shifts into two. Should test also increase to the extent that we should test outside Windhoek, depending at which sites, which region, we have earmarked at least a region like our lab like Oshakati, Onanjokwe, Engela, Keetmanshoop, Walvis Bay. These are possible hotspots where we think should these things start.
What has made them hotspots? Why do you consider them?
This depends on, you know that the north is highly populated. Walvis Bay, it's an entry port. The north also, east, south, it's also, it has got some entry ports. So, by the way, in terms of rollout, like I said, we will be driven by the direction of the ministry. We don't work in isolation. We are guided by the Ministry of Health as to where the test is demanded the most. So this is more or less how we are approaching it. We should be able to, our estimation is that should the West go to the West, we estimated that projection to be able to test at least 10% of the population. This is more or less
10% of the population. Within what kind of time frame are we looking at?
This is about 250,000 tests. We are saying within the next 6 months. But this depends on, of course, on the developments. This is just our estimation in terms of preparedness. So that should the West go to the West, we are able to do that much in terms of preparedness. That's our target for now.
Go ahead.
And we are also in terms of quality assurance, because every test we do in the lab should be quality assured. We are registering our COVID-19 test with our quality assurance service provider. These are proficiency test service provider where we are able to receive a blinded test to report on it whether it's positive or negative. We don't know the outcome as we test it, but they know. So this is one element also which we want to strengthen in terms of quality assurance so that our results are quality assured. Yes, so far that is our preparedness. In terms of resource settings, we all know we are in a country of limited resource settings. There may be a possibility of maybe a decision, depending on the pandemic, whether to go for mass testing. We can be ready depending on the resources available, because it really costs a lot. For now, we can look at just limiting the cost on reagents and supplies. You are looking at about $954 per test per person. So if you multiply that with the number of tests you are going to do, it's quite a high amount of money required in order to do these tests. Yeah. Otherwise, we are there. We are with the ministry. We have the same strategy. We are part of the surveillance team and the laboratory team. We discuss these matters every day as they develop.
Yeah. Dr. Bernard, Dr. Mata, I will come to you with a question. But can I just turn to Dr. Alfiku first? Is this testing, this mass testing, part of our national response strategy?
Well, it is included in the national response strategy, but in a more targeted way. We haven't really gone as far as thinking of testing on masses. It still needs to be targeted because it needs to be guided by the number of cases that we're picking up and the number of people that we're testing. If we test 1,000 people and out of that, only one case is positive, then we perhaps still not doing bad, depending on how we choose our sample. My colleague mentioned 10%. That's actually a worst case scenario, so to say, in terms of WHO modeling. And there are very few countries who went up to 10% of the population. And this is not to say that we can't go there. We simply don't know how this pandemic is going to evolve. But the Ministry of Health, the response team, and indeed the country, Namibia, will be a little bit focused and guided by the current situation. If we get an exponential growth, meaning that the current 16 cases become 32 next week, then we see we are facing a deadly situation, which we hope not to. But if we are just lingering there, next time it will be 17, 18, 19, while we are still testing, then we feel fairly confident that we are ahead of the virus.
But how effective would the testing the testing strategy be in containing the virus? First of all, in tracking, tracing, and containing the virus.
Yes, we actually started moving to what we call active surveillance now, where we pick up cases like I highlighted in my opening statement, and that the data we get out of that active surveillance will guide us further as to what action we will have to take going forward. Yeah.
Okay. Dr. Mhata, can I turn to you? You represent the WHO, but you are also a Namibian, so you would know obviously what about the next question. Now, if the virus were to hit the informal settlements, what would the devastation be? How would it pan out? How would it play out there?
Good question. You know, if the virus has to get into any community, and then that community is having a problem of social distancing, overcrowding, so to say, then it will be difficult, of course. But our way for looking at these things is usually just to ensure that we provide, as government, Ministry of Health, as community leaders, we provide the necessary information, how to protect oneself, how to protect our own family members, the people around us. So no matter in which circumstances and living conditions we are finding ourselves, but of course let's equip the people, the communities with necessary information of hand washing, regular hand washing, of respiratory etiquette, of social distancing. Let them try by all means to ensure that they are seen to be cooperating with government to protect themselves and others.
But would they be harder hit than the other areas like Ludwigsdorf, for instance?
Well, this is a challenge in itself, judging even from or looking at hepatitis E, for example. You find that, if it's in informal settlement where sanitation and water, access to water is a challenge, then you have a problem. So obviously, we cannot rule this out, to say that if a COVID, which is spread through droplets that are, generated from coughing of infected person, and it can fall on surfaces and whatever. So where you have overcrowding, it will definitely be a challenge. So, but what we are saying is that yes, it will be a challenge, but we should mitigate so that at least we are able to equip the people with preventive and protective measures to protect themselves and their families.
Dr. Bernard or Mr. Mukumbi, either one of you. Well, in terms of this testing, the testing strategy, Are you going to perhaps start with the vulnerable communities?
You mean testing the most vulnerable communities?
Yes, first.
Well, it depends which tests are we advancing. If it is a tracing of symptoms and, leads, then basically anyone irrespective. But the point you're making on vulnerable, especially people over the age, I would say 70, just to cover myself. So they are vulnerable because we see that a lot of people who actually have complications are people over the age of, mostly age of 80, let me put it that way. So they need protection. They need more social distancing than anything or anybody else. To the point that even if we try to sort of opening up the lockdown, they still need to be somehow protected because they remain vulnerable. And that goes with people with comorbidities like diabetic. I just picked up in one of the studies that more diabetic persons actually die than those that have got high blood pressure and other comorbidity. But that's just one of those. So we need to protect them. Pregnant mothers, we need to protect them. All of those, I think the protective effect will be a little bit longer, even if we pass through the pandemic and just have sporadic cases or so. We still have to take care of them because they remain vulnerable.
Thank you. Would you like to add to that, Mr. Makumbi?
Yes, like I said, the number of tests and our capacity is driven by or is initiated by the ministry. Once these people are identified who are vulnerable, who needs to be given the priority, we should be able to come in and say we are able to test. Depending on the numbers of the people identified, we have the capacity, like I said. For now, for example, each laboratory all over, we have about 39 labs. We have triple packaging material for each lab, which is ready to come in and receive a test. For now, we are testing centrally and ship the specimens to Windhoek. Until that time when we say, okay, maybe we should roll out and decentralize testing, then we should be able to test on site as well.
Dr. Bernard and perhaps Dr. Mata as well, we hope not, but there is a real possibility that there has been some infections within the community, local infections. If that is the case, and after the 2-week window period, it emerges that they're displaying these symptoms, what do you do? What do we do as a nation? What happens then?
I don't know if you want to answer this epidemiology, but the situation is unfolding, and we don't really know what will happen next week or the week after. All we know is the biological behaving and a whole lot of data about the virus that we pick up, but how it will play it ourselves here in Namibia, we're not sure. We only know the little bit that we have covered so far. So all our strategies and action will depend on what are the data telling us at that point in time. But we are ready to face any eventuality. Maybe not entirely ready, I must qualify my statement, but we are closely monitoring. It's almost like watching a drama on stage. We will check what phase of the virus is actually playing it out. And based on that, we move on the virus. But on more epidemiological data, I think Dr. Mata can give us. He's a specialist in that field.
Okay, so all that we should do now, of course, whether we are suspecting, of course, that is the fair, approach, because if you are not suspecting that you might be having a community transmission, you will just relax. So, but what we should do is I'm happy that the lockdown is going to take effect. We should really try, by all means, to prevent community transmission if it didn't happen yet. But of course, in case we will have evidence that we have many cases that are not linked to those imported and clusters that we already know, and then we reach a situation and description and conclusion that we have community transmission, then we have to make sure that we are reducing the number of cases. We are making efforts to slow the transmission, and we have to redouble efforts to contain and stop that community transmission. Otherwise, if we don't take a resolve and make sure that we stop it, it will finish most of the population. So this is how serious it is. So let's try by all means, if we don't have it now, the community transmission, let's prevent it at any cost. And then once maybe for one or other reason it is really with us, let's try by all means to stop it as soon as possible.
Thank you. I am going to invite the journalists that are here to ask questions. So can I get the first, any questions? Yes, can you come up to that mic and introduce yourself, please?
Good afternoon. My name is Salima Henok from the NBC. My first question is to Dr. Haufiku. I just wanted to find out if perhaps you have a time frame as to when the mass testing will start in terms of maybe getting more people to be tested of COVID-19. Is there perhaps a time frame as to when it will start during this time of state of emergency? And also my other question is to Dr. Boni. Yes, it's to Mr. Boni. I just wanted to find out if how many cases, confirmed cases, that we have now of COVID-19 in Namibia were tested through NIP. Thank you.
Thank you. Go ahead.
Did you say the time limit for testing?
Yeah, I just wanted to find out when...
Come take it.
The mass testing for a lot of individuals, just to confirm if we still have, like you mentioned earlier, in terms of cases, just to find out if we have more cases of COVID-19 in Namibia, besides from the 16 that we have now. So, is there a plan, a strategy as to when that will start?
Yeah. No, thanks very much. I just mentioned that we started the active surveillance. This is part of the strategy to check if community transmission is taking place, or any other information that may guide us, our strategy going forward, basically. So we're hoping that in the next 2 to 3 weeks, we will be somewhere halfway already in that process. And it will be an ongoing process because we need data from that to guide our decision and our recommendation to decision makers, like policy decision makers, like cabinet, etc. So it's an ongoing process, but we are almost midway. Hopefully in the next maybe week, 2 weeks or so, we will do more, we will have more results of testing. It may not be that enough, but we'll keep on pushing so that we meet epidemiological criteria of data that will help us make informed decisions. So it's an ongoing process.
And yes? The second part of your question was to...
The other one is yours, I think.
I just wanted to find out how many cases that we have now of COVID-19 in Namibia were tested through the NIP.
Yeah.
Yes, there's a total of 16 positives in the country. The first 2, of course, that time we were not ready. They were tested by NICD in South Africa, the National Health Laboratories. And subsequently, we started testing locally. And we have inter-referral between us and PASCE. There are times when they send some specimens to us, and we did some. And we have so far if I may not be speaking under correction, out of the 16, should have tested 11 of them positive, 10 or 11, but I'm speaking under correction. But in total, there are 16 in the country. We have tested the majority of the positives.
Thank you. Second question? Please. Come. State your name, please. Go to the mic. Thank you.
Hi, Jana Marie Smith from
Can you
Namibia
speak
Media Holdings.
closer to the mic? Thank you.
Dr. Hafiku, and then perhaps the NRP can also then answer. I'm just curious about the capacity. But I think you said by the end of the month there will be a capacity to test between 20,000 to 30,000 people. Is that correct?
Maybe my colleague from the lab perhaps mentioned that. If he says that, then I'll believe it, because he's the one working in the lab.
Okay.
Yeah.
So to Dr.
So it's all I can say to be very, very good news to us, because capacity is one area. Yeah, please go ahead.
I think that's also what I wanted to know from you. Are you happy to know that that's the capacity you would have at the end of the month?
Absolutely.
And how much of that would you want to be used as soon as possible?
Yeah, absolutely. The only thing is, when we say end of the month, we are basically saying in the next 2 weeks, unless if we say it's end of May. But what makes me happy is the fact that we have that capacity now to test, as we are hearing from the lab, because that has been one of our limiting factors. The reason why we had defined criteria for testing and only testing people that are symptomatic, not asymptomatic patients, is because we were actually worried that reagents and test kits will be running out and we couldn't test. So to have capacity is very good news to us.
And will the NIP continue to source the necessary materials to continue having the capacity over the next 6 months or more to continue testing a lot of people?
I think it's to him.
Yes, sorry.
Yes, like I said, we have our reagents, consumables, and personal protective equipment. Some are on order, they're in the supply chain pipeline. And we are having some have confirmed estimated dates of arrival, some not yet. But according to our projection, we have placed these orders, and the expected dates of arrival or delivery is between this week and the 3rd week of this month.
Okay. While the next reporter journalist is getting ready, I would like to throw open a question, particularly to Mr. Makumbi. When is this testing, this countrywide testing, going to be rolled out? But more importantly, these laboratories in the rest of the country, are they equipped with the facilities to be able to test for the virus?
Yeah, like I said, when to roll out, by and large, will be determined by the direction from the ministry. In terms of preparedness, like I mentioned earlier, as we speak, each lab has a gene expert instrument with a capacity of testing 1 run, 4, 2, or 16. So in terms of equipment, they are equipped to start running as soon as we receive, of course, the reagents that goes together with that particular equipment. In terms of personnel, of course, in the outskirts, in our district labs, most of our labs are smaller ones, are manned by 1 or 2 or 3 persons at the most, very smaller labs. That we have also sketched out the possible number of personnel that we may need there. There are personnel which are non-technical, for example, data capturing. There are those who are actually should do the actual test. So we should be able to to do the test because those technical people are already there. It's a matter of once those particular reagents are available, it's a matter of commissioning that particular instrument, training the particular scientist on site how to do the test, because for now, we should be able to have time before we roll out, do a test, by the way. There is installation of the instrument, verification of its performance, and then training of the user, and then you set up all the quality management system around that testing. So that we should be able to do within a couple of days as soon as we set up a site.
But Mr. Makumbi, the testing is centralized as of this moment.
Yes.
When are you going to decentralize it? And would that not be more effective?
Yes, decentralization is driven by the test volumes and the demand out there. So for example, for now, we are testing, we haven't reached 50 tests per day in Windhoek. So you can only decentralize as the demand shows you, indicates that you should decentralize. Like they were talking about the stage of the outbreak. So the more tests are requested, and from where they are requested, it indicates you or shows you where to decentralize, which one is the priority area. So as soon as we get all these indications, as the pandemic develops, we should be able to respond as quickly as possible to where we are first required to decentralize.
Just to add to that is that from the clinical case management point of view, we hope the process of decentralization is not going to take us long, because if you look at countries that are overrun by the pandemic, they had a lag, they had a delay in setting up certain structures. And the moment that you want to make the lab in Katima functional, Katima is already overrun by a number of patients. We hope that, and we don't want that situation actually to happen. That's why we're really pushing that, like my colleague mentioned, that in those hotspot areas, we should have everything ready basically. A testing, at least in one, even if we don't put the machine or the reagent that day, at least we must have the whole thing ready. If the epidemic doesn't come the way we fear, then we dislodge our equipment, no problem. But it would be terrible if we have to struggle and the car tire based on the way taking a machine to Ashakati. So that we obviously have to avoid by all means, that we have all the basics in place as long as they are safe. We set up our testing center and maybe even treatment center, because you can't just have testing center without treatment, because the two go hand in hand. For this reason, we discussed it even this morning. The Clinical Case Management and Infection Prevention and Control Committee, or PILA, is sending out a memo to all the regions to standardize our testing and treatment capacity. And we currently benchmarking on Robert Mugabe Clinic, which is our centralized center actually here for testing, apart from the unit in Windhoek Central Hospital. We see our colleagues in the region telling us we are ready. We have seen NBC going to other regions. But we need to go there from here to make sure that we are really ready. And what needs to be done must be done now during this window period. So that when the worst comes, which we hope will not come, at least we are ready. That's our message. Yeah.
Thank you, Doctor. Yes, you'd like to come up, please?
Good afternoon. My name is Shamaine Gashihewe. I'm a journalist with the Namibian newspaper. I have two questions. One for Dr. Haufiku. I wanted to find out the issue of the passengers who were stranded at the airport. I think about a month, 4 weeks ago, you went to assess the situation, Dr. Haufiku, and you let them go without basically asking them to quarantine or without ordering any form of mandatory quarantine. I wanted to find out, is there a way that the ministry is tracking them down since you were there at the airport with them? And then maybe, does that mean you would also need to undergo any testing? And then I wanted to find out, okay, lockdown is another 2 weeks. Do you think it's enough time for us to contain the virus, that it doesn't spread to the community? Thank you.
Yeah. On the passengers that were stranded at the airport, I think we didn't really get the picture. That was one of the unfortunate, difficult situations we faced. First of all, let me just put it on record that 40 to 50 of the passengers from Deb Marine who were coming off the ship for the 14 or 28 days, they were quarantined. I haven't picked that up in any of the media. People concentrate on all other sort of things, but those Deb Marine passengers were taken for quarantine. And it's because it was arranged, they were informed before they landed at Hosea Kutako that they would be quarantined. It was just a matter of delay in terms of logistics. The difference of these patients gave us a very difficult situation. In fact, I thought, and I still believe that if we had not, or let me say I, because I'm the one who was there, if I had not told them, but I mean, I didn't just act out of my own thing, I act out of the situation. If we did not allow them, or I did not allow them to go home with the message to self-quarantine, we would have been in court almost that whole week. There were 2 Supreme Court judges or senior councillors who were already even trying to speak to the president of the country and asking, why are we here? The reason is not necessarily because of coronavirus. The reason is that they believe that they were treated unfairly because on that same plane that came from South Africa that day, a number of passengers were dropped at Walvis Bay Airport, including some of the crew members. Nothing was done. Nobody said you are going to be quarantined or anything like that. So when they landed here, they were told by Air Namibia or officials at the airport that 1 or 2 planes already landed before their plane. We didn't quarantine them. We didn't ask anything. So they were asking, why us? Why do you want to quarantine us and you did not quarantine the other plane that landed in the morning? And that same day, I received about 40 passengers, Namibian passengers who came in from Amsterdam with KLM. It was well arranged. Everybody knew. We went there with Ms. Masabane. We talked to them. They were escorted to Marienda, happy, very happy. So this is a very unfortunate situation that came up. And we had to let them home for self-quarantine on technical basis. And it's a mistake. It's clearly a mistake. And I think it has to do with the way we communicated with the airline, because even Air Namibia was apparently not even aware that the quarantining of anyone coming from outside has already taken place. They had a letter, which I have seen, telling everyone that on the 28th of March, we'll suspend all the flights. So clearly, even Air Namibia was under the impression that they can still operate without any quarantining of passengers. It's a terrible miscommunication, actually. But yes, those people are in the community. I am just hoping that it did not cause any community transmission that we are talking about here. A number of them, we gave them the call number if they developed symptoms. First of all, we told them, because I was not alone, I was with the public health official. We told them, you go home, you isolate yourself for 2 weeks, you don't make contact, all the preventive measures that we're talking about, and you must phone this number if you develop any of these symptoms. Well, we can only hope that maybe majority or all of them did not develop these symptoms. But I agree that was not the right thing to do. But we were under duress. we could not do otherwise. I'm just glad that no such situation was reported after this. And now, part of testing to check if community transmission is taking place is also to include all those people who were in the country without quarantine. And they are not the only one. Cars were coming in here from Noor-Uber. You know, some South African apparently saying we want to spend the lockdown in Namibia. So we were not locking them down. That's very unfortunate. And that's why we need to be suspicious of community transmission. And we need to be aggressive in testing and trying to see if we pick these cases up. I hope I answer your question. On the, you ask if there is enough. I probably forgot that what you say. If there is enough.
Second part of your question?
If there is enough. Whether 2 weeks is enough. Oh, sorry, I probably talked too much. I apologize for that.
Okay, Dr. Haufiku, before I get to that second question,
yeah.
I wanted to find out whether you would also be eligible to be tested.
Those
because you were at the airport as well.
Those who were at the airport.
You, because you were there with them.
I went for a test and I gave you my result the other day, guys, you know.
Okay, my second question.
But you see, the test of one individual is only good to protect you. I'm just one of those. Yes, I went for the test. Okay. And my result are at the laboratory. You can ask the gentleman here, he will. But it doesn't absolve me from the risk. I'm with you here, I'm in the society, so I have to be careful all the time.
Okay, my second question was, is 2 weeks enough time
Sorry?
to, whether the 2 weeks, the extended 2 weeks for the lockdown, is enough time to contain the virus from spreading to the community?
Maybe not entirely, but it's something much better than not locking down at all. If you look at the graph from the Department of Health in South Africa, and I know Professor Karim Abdul Karim, or Salim Abdul Karim, and Mr. Pillay, who did this modeling, very outstanding scientists. If you look at two of those slides, and they compare them very well, the slide that shows or model a lockdown for just about a week or so, show the curve slightly flat, but not that much. The moment you extend the lockdown, then the flattening of the curve stay very low. The moment you hypothetically lift that lockdown, then you got an exponential growth of cases. These are scientific data. It can only give us one conclusion, that locking down does intercept transmission of the virus in the community. Perhaps not for good, but at least for a period that gives you a window of some kind of preparation, strengthening your mechanism, etc., etc. It does have an effect, a positive effect, yes.
Thank you very much. We don't have much time left, so I'm going to ask the panelists for their concluding remarks. Can we begin with you, Dr. Mata?
Well, all that I can say is that from WHO, we continue to support countries, in this case Namibia, by providing technical information, technical advice, and particular in how to contain the outbreak. So there are different teams that are addressing issues of well-coordinated response, issues that are guiding the government and the ministry on what are the accredited or approved treatment or supportive care modalities available, and issues on risk communication. So we are really requesting that communities trust their government, the Ministry of Health, information sharing, and also from WHO as a source of credible and trustworthy information databases, rather than relying on the media, the social media. Some of the information really is really misleading. So with that, I think let's continue to know where to get the accurate and correct information from government and WHO. Thank you.
Thank you. Thank you. Mr. Makumbi?
Thank you. Yeah, in terms of testing preparedness, our finger is on the pulse. We are prepared, we continue to prepare, even for the worst case scenario. We are preparing to roll out if there's a need to roll out. At the moment, it's centralized. We have a transport logistics system for the specimen movement from the point of collection to us, in partnership, of course, with our national courier, NAMPOST, which we use to transport all other specimens from points of collection to central testing in Windhoek. So we are ready together, directed by the ministry. We are in one team. We are in communication, and as soon as there are particular indications for testing or particular special advices, by the way, we are also advised by the CDC in country, is part of our team as well. So we are moving towards reaching at least that point of preparedness. Even though under limited resource settings, you cannot reach a very desired point to say you are completely prepared, but we are prepared. Thank you.
Thank you. Dr. Afiko.
I think we are doing not too bad. We are doing well according to the available data that we have. I mean, you can go to the Johns Hopkins University and check how many countries are staying up to 10 days, almost 2 weeks, without picking up a case. That's a good sign. 16 cases, also a good sign, because we are about 2 months now. We just have to do more. We need to do more testing to back up our cases with robust data. So testing, we need to test. We need to continue with all these measures. Social distancing, all the measures, including the obeying of the lockdown, because lockdown means intercepting transmission or possible transmission from one region to the next, and mostly to the vulnerable. I plead for discipline among our people, that if there is a roadblock there, it's not there to recolonize you. It's actually there to maintain order and to make sure that, as inconvenient as it is for all of us to stay in one place, Namibians are normally a mobile population, but for the sake of this pandemic, for the sake of all of us in Namibia, let's follow the regulations, the rules, the disciplines, the guidelines, and help each other. Help each other. The one who doesn't understand, or the one who hasn't got access to something, then we'll pass through this pandemic. I am quite optimistic that if we do the right thing at the right time with the right people, we'll get the right results. So that's my conclusion.
Thank you. Yes, and as we've heard, at 16 cases, Namibia is doing relatively well. However, we cannot be complacent. So you need to follow the health directives. We need to obey the regulations around the lockdown, and you need to remain healthy. From all of us, it's thank you, and I'd like to thank the panelists as well. Thank you very much for informing the nation and for the good job that you're obviously doing. From all of us here, it's goodbye.
Thank you. Thank you.
Now, of course, whether we are suspecting, of course, that is the fair, approach, because if you are not suspecting that you might be having a community transmission, you will just relax. So, but what we should do is I'm happy that the lockdown is going to take effect. We should really try by all means to prevent community transmission if it didn't happen yet. But of course, in case we will have evidence that we have many cases that are not linked to those imported and clusters that we already know, and then we reach a situation and description and conclusion that we have community transmission, then we have to make sure that we are reducing the number of cases. We are making efforts to slow the transmission, and we have to redouble efforts to contain and stop that community transmission. Otherwise, if we don't take a resolve and make sure that we stop it, it will finish most of the population. So this is how serious it is. So let's try by all means, if we don't have it now, the community transmission, let's prevent it at any cost. And then once maybe for one or other reason it is really with us, let's try by all means to stop it as soon as possible.
Thank you. I am going to invite the journalist.
Thank you. That was the conclusion of today's session. A big takeaway was at the end when Dr. Bernard Haufiku again said, while Namibia is still doing quite well with only 16 confirmed COVID-19 cases, the fact remains that we still have to do better, and he said we need more testing, a lot more, to be sure that the country is doing how the country is doing. Thank you.